Good morning, everyone. Uh, After learning so many things about children, how to handle a child, and then neonate, and then prenatal stage, and then everything we have learned sequentially, and now it's the time to learn what is the psychology, or whether it is a pathology. Psychopath, psychology has become so bad that it has, the word we have given is psychopathology of death in children. We all know child death is always different from a adult death. What is the pathology behind it, and how to handle the bereaved parents? This is what Gujarat team, GCI will please Gujarat team will speak about, and what I'll suggest Dr. Preeti, because this is your team and you know them about both of them very well. So I'll request you to introduce Savan and Dr. Bhavna, and then we will start. Thank you very much.
Good morning, ma'am, and good morning, everyone. Dr. Savan, he is second-year junior resident at our Department of Palliative Medicine. He is sincere, hardworking, knowledgeable resident. Though they have come before 6 months only, but they are promoted fast. So second year, he has presented poster on management of intractable dyspnea in a patient of metastatic soft tissue sarcoma of right side. Case report at IAPC 2023, and he is prepared on this difficult topic very nicely. We didn't get much elaborative literature, but he has tried his best. So, ma'am, it will be your task to discuss later on about more and more. Savan, you may start.
Thank you, ma'am. Good morning, everyone. I will share my screen.
Dr. Bhavna is a concept faculty at GCRI, she of palliative medicine, just for newcomers. So please go ahead, and we all will discuss together because it's a big topic. It's a difficult topic, and I think we will ask comments from all the senior people, those who are present here, or junior if they want to give. Okay, go ahead.
Yes, is it visible slides?
Yeah, visible and clearly audible. Don't worry.
Oh, thank you. Good morning, everyone. So the topic of today's discussion is psychopathology of death in children and bereavement care for parents. So first of all, although an inescapable part of life, that is not a prominent theme in most people's day-to-day life. Most adults faced with their own mortality at the end of life grapple with difficult existential and practical questions they have not negotiated before. If this is the case of adults, then what must be prospect of looming adult that be like for a child? And how can we help them with the difficult uncertainties they must face? Now, what understanding death of another? Children's more general understanding of that can be broken down into four primary concepts. One is universality, that means all living things die. Second one is irreversibility, once that is forever. Third one is non-functionality, all function of the body stops. Fourth one is causality, what causes that. Infant and toddlers are generally not able to differentiate death from separation from caregivers. And partial understanding of universality, irreversibility, and non-functionality usually develops from 5 to 7, but a more complete understanding of that concept, including causality, is not generally seen until around age of 10. So children who are more than 11-year-old will better understanding regarding the concept of this death. Information about prognosis is often filtered in transfer from physician to parent to child, and each step may include delays. Families want to receive information about prognosis and earlier recognition of grave prognosis by doctors, and parents is associated with earlier discussion about hospice and better home care. Even if prognosis has been communicated to parents, the information is not always passed on to the ill child, particularly if parents disagree with the physician opinion. There is one ill child, and in most of scenario in pediatric age group, physician will not pass on the message regarding children's health prognosis, regarding condition of the child to their parents. And if this is not going on, then how come the children will know regarding the condition of his or her his or her condition regarding the, yes. So there is a very delay during every step, and at the end of the day, children will never know regarding the condition of his. When information about prognosis is received, some children have a lot of time to negotiate their understanding of it, whereas others have very little. Most children with the cystic fibrosis have decades to come to an understanding of what their terminal illness means to them. Whereas in case of cancer, there is only few hours or days until the death. One study reported that half of initial end of life discussion with adolescents who died from cancer began with patients within their last month of life. Another study of children, mostly with cancer, who died in hospital described do not resuscitate order being addressed for the first time on the last day of life in 58% of cases. So you can clearly see that there is a clearly no any communication regarding end of life care and this type of things being told to the patient. Children's language to discuss or think about that may be limited to cultural references or other second-hand information taken out of context, and parents may be able to provide a vocabulary and correct important concepts. Adolescents in particular feel it is their right to know what their prognosis is, and even younger children often know or suspect more about the prognosis rather than what they have been told. Now, what are the symptoms? It is physical, cognitive, and psychiatric symptoms. The individual child's dying process and how it is managed by caregivers are likely to influence how much a child is able to deepen their understanding of dying, even when a poor prognosis have been already disclosed. For example, if the primary focus of the patient, family, and caregiver throughout the dying process is just to reduce the pain, then it might get leave little opportunity to address more existential concern. Healthcare staff address 82% of physical symptoms compared with only 43% of psychological symptoms. Furthermore, only 56% of parents' psychological symptoms were addressed, possibly leaving them ill-occupied to support their children and more at the risk of psychological complication of bereavement. So, mostly at the end of life, physician or treating doctor and parents, family are focusing just on reducing the pain, and there will be no any focus on other symptoms which are concerned to patient only, like vomiting, decreased sleep, uh, yes, coughing, breathlessness, constipation. So these are the main symptom which bother to patient, and we are just focusing on pain. So we have to focus on that well also. Desire to continue living. Young terminally ill patients may become increasingly aware of still being alive, wanting to live life to the fullest. This should not be mistaken for lack of understanding of their illness. A parent interviewed in an examination of how families are supported in hospice was surprised to find that children were there to live to have the best time possible. The same study found that young people with terminal illness want to go out and meet other children who are not ill. So this is the simplest thing we can easily understand, that mostly ill children will want to stay and play with uh, other their friends, colleagues who are very good in their health, and they want to live their life with them. Patients may feel that if there is nothing they will become, they have lost their primary role of or work. This may contribute to depression or manifest as efforts to maintain the role of the child who is still able to impress his or her parents and make them feel optimistic about the future. So here comes the communication, how the ill child will communicate regarding their condition. Children and adolescents want to receive information about their illness and treatment, and lack of communication only leads to the increased anxiety, mistrust, and isolation. Death is best discussed in honest, concrete, and unambiguous terms. An important part of the communication is achieved by being present, listening, and asking open-ended questions to assess what children already knew or believe. In very young patients, some communication might be through play or drawing, or rather than through speech. So I can give you one simple example regarding communication. There was one movie, Tara Zameen Par, where the boy is suffering from dyslexia, and he has been sent to a boarding school. Now there in boarding school, he has no any friend, no parents. He is alone. He is suffering from anxiety, depression, fear like symptom, and he is not able to communicate with any other person. So he has just simply draw a simple book regarding what he thought in his life. So this is a simple example. As example, I can give to you. Clinician and parents should arrive at a set understanding of what level and type of information in appreciate for each child, and appropriate level should not be chosen simply by age. For younger parents, family-based or group-based intervention may be helpful for starting difficult conversation in a non-threatening way. Some a part of law reflect children's understanding. The concept of a mature minor is now quite prevalent, with difference between region remaining law still evolving. In Canada, Supreme Court ruled that young people under 16 will have the right to demonstrate mature medical decisional capacity, giving children younger than 16 the right to make even life and that decision if they are deemed to have capacity to do so. Similarly, in Belgium, where there is no lower age limit for euthanasia, but where parental consent is required. So now comes to the bereavement. Bereavement and loss are a familiar occurrence in palliative care, and appreciation of what constitutes grief and an understanding of the special circumstance of bereavement in the palliative care setting may aid clinician in attending to the needs and preference of families during this period of impending loss. The death of someone significant represents a multifaceted challenge for the survivor. They must adopt to social and economic readjustment emerging from this event and come to terms with changes in self-identity resulting from their loss, while dealing with psychological and physiological reaction engendered by the death. Bereavement in palliative care, the terminal period of an illness can be extremely stressful time for the families of dying patient. Although bereavement is usually the specific event that precipitates the mourning, which means sadness due to death process. For that occurs in the context of palliative care, a variety of circumstances occurring prior to the death. When death is preceded by a chronic illness, grieving in inexorable tired with the mourning loses the experience during the course of the illness. Three loss including one is altered relationship, second one is change in lifestyle, third is the forfeit of future dreams that will never be realized, progressive debilation, increasing dependence, cognitive decline, excessive pain. So what will be the normal manifestation of grief? First one is physical manifestation. Symptoms experienced by a bereaved person may include hollowness in the stomach, tightness in the chest or in throat, oversensitivity to the nose, oversensitivity to noise, spelling, sort of breath, weakness of muscle, lack of energy, dry mouth, and sense of depersonalization. So these are the some features which will be seen bereavement. Yeah, these are the physical symptoms. Now come to the emotional manifestation. For many, sense of self and numbness is the initial emotional response to bereavement. Feeling of anger and guilt are common. Then comes to the cognitive manifestation. Disbelief and a sense of unreality are frequently present early in the bereavement. It is also common to have a sense like a visual auditory of the presence of a disease. So here again come to the symptoms of separation distress. Yearning for and seeking proximity to the disease, loneliness, sadness, crying, guilt, shame, anxiety, anger, uh, disrupted appetite, disrupted sleep, as well as somatic symptoms such as tachycardia, stomach sensation, dizziness, feeling drawn to things associated with disease, social withdrawal, and disinterest in other people's. Confusion about one's identity and feeling lost or unsettled without the disease. Symptoms of trauma or stress reaction, which include disbelief and difficulty accepting the loss, shock, numbness, impaired attention, concentration, or memory. So grief pathway is there. Various models have been deployed to have us understand people's experience of grief. The extended grief cycle, which comes to the next in coming slide, indicating the roller coaster slide of activity and passivity of as the person wriggles and turns his or her desperate effort to avoid the change. So after the death of any person, the first and foremost the reaction or which in the grief cycle is denial phase. The symptom include avoidance, confusion, fear, numbness, blame, which last for only short term of period. And then comes to the anger. Anger, which means frustration, anxiety, irritation, embarrassment, shame. So during this phase, there are many chances that family or caregivers will attack to the doctor, treating physician, treating surgeon. Uh, so in recent time, this is a recent period of time, there are so many cases that physician has been, you have heard that physician or surgeon have been beat. So this is a phase in which family or caregiver are, he feel anger regarding the condition of patient. Then comes the depression and detachment. After that, there is a phase of bargaining, reaching out to others, desire to tell one story, struggle to find what meaning for what has happened. And then comes with acceptance. So there is a very uh, roller coaster ride regarding uh, phase of grief, bereavement in close ones to the death, the denial, anger, depression, bargaining, acceptance. Five simple steps are there. And after acceptance, patient's caregiver or family will return to their meaningful life. Yes. So key point: loss, which means the fact or process of dying, process of losing something or someone. Grief, the total active experience of loss impacts physical, emotional, spiritual, and social aspect of life. Mourning is our external expression of loss. It is a style of expressing loss. And bereavement is a state of having lost someone or something dear to you. So these are the four things which is very confusing to understand. But yes, grief, the total active experience of loss, impact of physical, emotional, spiritual, and social aspect of life. It lasts and changes over time. It is a natural healing process and not a pathological condition. Most intense distress lasts something about a year, often more to yes. Grief lasts in when you're very close person who dies, then grief period will last till a year or maybe more than a year. The first few weeks is a shock period. People report feeling numb or okay initially. A renewed intensity at 4 to 8 weeks. Parents who have lost a child describe much longer time frames needed for healing. So it is said that time of bereavement, time of this grief is equal to the how much you are loving that person, like parent and children scenario. Bereavement lasts for more than a year. Grief in the dying children. So there are so many questions in children. What is that like? What will happen to his or her body when he die? Why me? Why God? Why did God let this happen? Why didn't the medicine work? Where will I die? Well, where will I die? When will he or she die? Will I be awake or asleep? Will I be able to do the things that I want to do before I die? Regarding family and caregiver, how will it feel when I die? Will it hurt or not? How will my family and family's friend remember me after that? So there are so much questions regarding end of life. At the end of life, terminal phase of disease, children might be in their mind. Childhood concept of life and that infant to toddlers. Toddlers means below 2 years of age. Difference between sleeping and waking may represent early appreciation of being and not being. Yes. So just when age is less than 2 year, the concept of death is just a one simple thing, whether he or she is sleeping or waking. That means that yes, this is a simple concept of less than 2 years. After that, early childhood from age 3 to 5 years, expansion of the death concept include loss of loving and protective object. Death is a temporary departure, reversible, magical thinking. Then from age 6 to 10, appreciation of removal from one kind of physical existence to another, beginning to understand that death is permanent, death is personified, that is associated with grief for anticipated separation from loved ones or fear when seen as punishment for wrong acts. Adolescent from which are age more than 11 years, they have death recognized as final irrevocable act, yet accompanied by disbelief in the possibility of one's personal death. So age is more than 10. The concept of that is fully understandable to the patient. Below years of 10, there is patient have not full developed concept regarding their death. Around 6 hours process of mourning, recognize the loss, react to the separation, recollect and experience the relationship, relinquish old attachment to the deceased, readjust, reinvest in life. Children's grief. The child's capacity to cope depends on relationship with the person who has died, the nature of the death, the child's personality and the previous experience of death, the age, which both include combinedly chronological and developmental, support from others, attitude of significant others. So for uh, grief, what we can do. So here comes to the treatment portion, grief therapies. The first one is generally supportive aids. Basic aid to any form of grief is counseling. Counseling include the use of evoke, active rather than sensitive language to assess the expression of feelings, the sharing of photo album and special letters from the loud person writing about any unfinished business to draw it to a close, and optimizing attendance at culture or religious ritual to support the process of mind. Children can be encouraged to make up a scrap or memory book about deceased parents as an aid to their adaptive mourning. Second one is supportive expressive therapy. The most basic model is a supportive expressive intervention in which the person is invited to share their feeling about the loss to health professionals, how will listen and seek to understand the other's distress in a comforting manner. Third one is interpersonal psychotherapy. Any psychodynamic understanding of the patterns of relationship from childhood that repeat in adult life will inform these interpersonal approaches. Cognitive behavioral therapy. This offers a special contribution to chronic grief. Your continued connectivity with the deceased may be valued. Behavior approaches regulate exposure to the cues, optimize socialization through activity, scheduling, moderate in appropriate drug, alcohol use, and promote graduated involvement is in new roles and experiences. Pharmacotherapy. There are some medication which can be we can use to overcome this grief. Benzodiazepines are anxiety and assist sleep, but words of cause and should be offered about intermittent use to avoid tachyphylaxis and dependence. Antidepressants are indicated whenever bereavement is complicated by the development of depressive disorder, panic attacks, and wanted to see their adjustment disorder. If there is a insomnia, so we can give mirtazapine, otherwise selective serotonin reuptake inhibitor, or combined noradrenergic and serotonergic reuptake inhibitors are indicated. An integrated approach to the treatment of complicated grief incorporates balanced combination of pharmacology, individual psychotherapy, and socialization through family or group. Some difference in diagnosis regarding grief. First one is prolonged grief disorder. A subgroup of bereaved people experience prolonged grief disorder, yearning for the deceased person, preoccupation and thoughts and memory of the deceased. Emotional pain and disbelief about the death can occur in both grief, typical acute grief and prolonged grief disorder. However, prolonged grief disorder is marked by maladaptive thoughts, excessive avoidance of reminders of death, excessive dysregulated emotions, and dysfunctional behaviors that do not occur as a part of the acute typical grief. So these are some few symptoms which differentiate from prolonged grief disorder and from acute typical grief. Prolonged grief disorder persists for at least 1 year. After that, then it will called as prolonged grief disorder. Second differential diagnosis is major depression. Typical acute grief and major depressions are both generally characterized by feeling of sadness and guilt, a diminished ability to experience positive emotion, and insomnia. So four symptoms are similarly between depression and grief: sadness, guilt, diminished ability to experience positive emotion, and insomnia. While in acute grief, the predominant effect is a yearning for the decades. These feelings are typically intermittent and oscillated with a period of respite when the pain subsides, and euthymia. Euthymia means a state of living without mood disturbance. By contrast, major depression is characterized by perceived and persistent sadness, feeling blue or down in the dumps, and inability to experience positive emotions most of the day, near every day, even when dysphoria abates, euthymia, and positive emotions rarely occur. Third differential diagnosis is post-traumatic stress disorder. Symptoms that can occur in both conditions include intrusive thoughts, avoidance, avoidance behavior, and emotional dysregulation. In addition, acute grief and post-traumatic stress disorder may include frequent incest images of someone who has been dead. However, sadness and yearning are the user response in acute grief rather than fear, which often occurs in PTSD. So that is regarding the psychopathology of child and bereavement.
Dr. Preeti, Dr. Bhavna. So I think Savan, what I can say that for a 6 months old PG student, this topic was so tough. And I sometimes feel this regularly. This is not today, but that MD palliative medicine immediately after finishing MBBS is little heavy for the young boys and girls, those who are coming straight away after finishing MBBS, thinking that they are going to do MD, and because of sometime because of this situation, or sometime because of these topics. So if we consider this in our mind, I think you have done very well. You have brought some good articles, and you have referred them. So it was really good, Savan, for your age. So
Thank you.
Dr. Bhavna, please go ahead, and we will see the question answer in case if there are any.
Yes, ma'am. And in Indian scenario, for bereavement, it is they understand socially and take care of each other. But this point, if they require some medication, they usually hesitate and they don't ask about that for us because they are coming for their children's treatment. So we should ask them positively, do they require some aid, pharmacological aid we can prescribe them. And it happens frequently.
Anyone wants to add anything in this topic with your experience? I can see I have seen a lot of this bereavement of children. I've interacted with many parents, and this is absolutely true that 1 year when they come and meet you, they are very sad, and they always remember that what has happened, what went wrong, what could have been we have done better. They discuss only this thing, and slowly after 1 year, if they come with the something in their mind that we want to start a scholarship from. And yes, the day before yesterday, one of the parent came and he said that I want to give a huge amount of money for research in cancer. So I think he came after a year. So 1 year is genuine, and is ultimately a big loss for parents. So 1 year, if they are coming and they are crying and they are asking you questions, that what has happened, whether we could have done better, because they will ask the same question again and again, and whether we could have done better. Uh, although they remain happy that at least their child has not suffered, but still they will keep asking this question. So 1 year, the same child parents, this is, I'm giving one example. There are many parents, they come usually, and they want to keep you in touch with you. They really connect you with them so well, because you were the one, you were the one, you were the one there for the child when he or she died. So they really want to remain connected with you. They will come to you again and again. They will talk the same thing again and again. You should not feel that, oh, I have already explained last time why he or she asking again. uh, they may cry, and slowly this crying incidence and then the crying intensity will reduce, and the same parents will come with some kind of a ideas that we want to do, because they want to remain connected. That's why they want to start a scholarship, they want to give some kind of a research money, or they want to start so many NGOs I have seen, those who are looking after kids. They are the people, those volunteers, those who are working in these NGOs, they are, or they all, most of them have lost their the young ones in the some or the other part of the life. So see, this is the way this cycle is going to go. uh, Very rarely you will find pathological or a prolonged or a complicated grief, when you will find that after 5 years also the same condition is there. They are crying, they are unable to adjust, they are just keeping their things same. They are not they are not aligned to change in the house anything. So this is also a problem. So you can definitely, we should have a good counselor, and we should send them, we can send the consent, we can take help from psychiatrists, and they need regular and intense counseling. But otherwise, I think a palliative care, good palliative care physician, if they have done their responsibility, if they have done their job well, while patient was a child was in the end stage, if they have treated their symptoms well, the bereavement or grief will be normal grief, and this will happen that 1 year they will come and do the same thing, they will ask the same questions, but after some time they will get adjusted. So anyone wants to share their experience? Dr. Jennifer, please, would you like to share, or Dr. Nagesh, if you want to share? Yes,
Yeah,
please go ahead, Dr. Jennifer.
thank you, ma'am. Actually, my experience with pediatric palliative care is limited. So after I share, maybe those who actually do a lot of pediatric palliative care, we would like to hear from you. So thank you very much for that well presented lecture. So palliative care is, like ma'am emphasized, holistic care, and we, especially with pediatric palliative care, which I think is a hard subset within palliative care. The attention, yes, patient is our focus, but we have to constantly give equal attention to parents also, because though the child is going through a different kind of trajectory, physical, emotional, psychological, and all that, the parents are also going through a very difficult trajectory. And so maybe a little different from how we treat our adult patients, how we treat the caregivers and adult patients, parents, and also siblings should be considered. We should explore what stage they are in and how they are coping and what is happening in their own lives. That is very, very important. So definitely having a team approach to caring for patient and the family is important. And some of them will benefit from also psychiatrist help if they are really finding it difficult. I have come across families where sometimes one parent is fully involved and the other parent kind of copes by staying away. So what is happening in both, and how do we integrate them so that we prevent complicated grief? So I think walking along the caregiver, parent, sibling through the illness is very essential, and to get psychiatrist input if necessary during the care is also important. But we'll really benefit from hearing from those who actually do a lot of pediatric palliative care. Thank you.
So, do anybody wants to share? Anyone is there from Gayatri's team or anyone who is looking after children? Otherwise, I would encourage any resident who has come across with this kind of, because I know in AIMS there are so many residents, those who have worked, they are working with children and child.
Yes, ma'am, it's Amelia here. Good morning.
Yes, Amelia, please go ahead.
First, I want to thank Dr. Savan. It's a very difficult topic and he's actually done very well. So thank you, Doctor, for your talk. So, ma'am, one most important thing I want to say that it's an emotional turmoil for the doctor who's looking after a child who's dying. I know we focused on patient and the parent, but if we have to care for them, I think it's important that the junior doctors and the people, when they're posted for pediatric palliative care or when they're looking after children, find somebody who you can talk to. And if the parent is not able to come to terms, it's not your fault. It's not that you're not the person, you're the person who was not able to achieve what needed to be achieved. The parent needs their time. So it is not for you to think that I was not able to do what I thought I could do. It is different from adult. Jennifer said the very right thing, that siblings in this thing, not just the parent, are a very important part of grief and bereavement. There is a lot of interlinking between the dependency between them, especially if the age difference is a little bigger. Some older children look after the younger ones at home, especially in the Indian scenario. And so including them into the care is very important. The diagrams, Dr. Savan, that you showed is absolutely right. Many times children don't talk, but if you sit with them and you color and they color, actually you get to see some feelings that are there which they wouldn't have vocalized. And encouraging the parents or talking to them separately as well as together makes a big difference. They do hold back a lot of emotions. They try to be good parents. They don't actually say what's going on in their mind. Counselors and you sitting together goes a long way. And when you are doing that, you have to let yourself away from the other pressures that you're feeling, because if you are distracted, then parents are not going to actually talk to you. So I have looked after quite a few in a corporate setting, not in a teaching hospital. The setting is a bit different, but the time of reference also makes a difference. And the emotional state as to whether it is a precious child, whether it's an only child, these all go into the process of grief and bereavement. And so well done to you. And I think that through experience and talking and being a part of the pediatric team, palliative team that works in your institution, go slowly and please do talk. Self-care is very important if we have to take care of a next child. So please do that. Thank you.
So thank you, Amelia. I think you have touched upon very important aspect of this topic. Excellent. Thank you very much. And this is absolutely true that explaining about end of life or advanced disease status or child is dying is little easier in adult than in children. To explaining to parents is difficult. It is going to be difficult, and every parent or every child death will be different. So you have to learn these techniques and you have to learn this, and it will come only by practice. Only ultimate aim is that first aim is that child should remain symptom free, less suffering. They at least they should not have pain. They should die peacefully. Whatever you want to explain to the parents, you are explaining in right time, because every time is going to be different. When treatment is not acting, or treatment is not helping to the child, that time it is going to be a different explanation. When child is having a lot of symptoms and sufferings are increasing, it will be a different explanation, that you are doing something to relieve the suffering or to relieve the symptoms, but simultaneously we have stopped. We are not planning to continue the treatment for the disease. because it is not helping to the child. So something like this, we have to keep explaining in different stages. And finally, when end comes, it is going to be tough. This especially not to intubate, not to ventilate, because parents ultimately they will not leave hope if we have not explained them properly. So it is going again. It's going to be very tough journey for you also. And when this is also, I have seen that when a child dies, we are affected badly also, because I have seen myself that when it's young or teenager dying, in comparison with the old person who is 60 or more than 70 years old dying, I think the psychology of ours is also going to be very easy, not easy to handle. So it is important that, but this is universally true, which always remain truth, that you have to do what exactly required by you. So if you have done your job well, if you have done your responsibilities, if you have shouldered the responsibilities, because it's a tough responsibility, well, you will feel ultimately satisfied. Although you will feel sad if a child dies or a teenager dies, but ultimately you will feel satisfied that I have done what best I could have done for this particular child. So this was a tough topic, Savan, and you did it very well. I just want to ask you in the last uh, question to directed to, what is this question? Dr. Kankasha is asking, what is the experience of seniors here actively involved with pediatric palliative care with respect to consent and assent for clinical trials? So this Kankasha is asking. I don't think that there is anyone in from this team. So again, I say, Kankasha, that in clinical trial, again, in one or two clinical trials, we have enrolled our patients. Taking consent, I don't think consent, we should not ask for, we should not force taking consent. If you have explained them properly and if you have documented, I think that is more than enough. If parents are willing that this is whatever we have discussed, I want just that we both are signing, it is okay. But if they are not ready to sign, because taking consent without proper explanation is not a good idea. So consent, I don't think that we should be worried about DNR, DNI, but in clinical trial, what I have seen, that when everything fails and we say that we are going to try this medication for your child, because now the normal or routine treatment is not working, I think they will say yes. But if a routine treatment versus a clinical trial, I think most of the parents will say, then please go ahead with the routine treatment, and then it is going to be tough for clinician to explain. So this is what I can say, but anybody wants to add in this, I don't mind. And someone, before anybody wants to add, I will also request you, if you have any experience of any child's parents bereavement, so you can share.
Ma'am, I in recent time there was one patient who is a known case of osteosarcoma of right femur, and he's on best supportive care for just for pain management and supportive treatment. We are giving him a methadone syrup for pain management. Still, there was a complaint of pain. Both power of both lower limb was 0. And yes, the main complaint of patient who is 16-year-old is मुझे ये पेन से मतलब छुट्टी दे दो मुझे बस. That was the main complaint of that patient. One thing is the patient is living just 30 kilometers from our hospital, GCRI. We are having a home visit from our hospital. We have done home visit and we have given one trigger point block at the right thigh fold. We all know that this is in case of osteosarcoma, this trigger point block is just like giving just symptomatic relief. There is nothing to do with pain treatment and all that. After 1 week, patient called me that please give me that injection. It is very good for my pain. Yes, so patient, we told that we are not, it is difficult 30 kilometers home visit and all that. So patient and their family came to emergency, like 30 kilometers is very difficult there. They have to lift the patient almost 50 to 55 kg, both power of both lower limb is 0. And they came to emergency just to told me, just give me that injection, otherwise I will die with this pain. So at that time, it is very difficult to how to tell that patient who is able to understand all these symptom, all this his condition, despite he is telling me that give me that injection, otherwise I will die. So there
Very
is
good, Savan. So I think these are the incidents which will make you strong and will make you experienced physician and experienced palliative care physician. We should always remember that we should do our best, and we should not be very, it's like our responsibility is to make them understand as much as possible and give them pain free, keep them symptom on pain free as much as possible. So I think one or two last questions. We have only 9 minutes now. Dr. Manish D is asked, has comment that group therapy definitely it is someone has also explained in one research study shown that last 5 years old children, they just want to play with the with their friends at the in the end stage of the disease. This is true, and I have also seen many children in our ward. They just want to play the cartoon with their siblings or their friends, and they remain so happy. Even if they are dying, they are not worried about death. They are worried about pain, and they just remain happy. And when they are happy, their parents are also happy. So it is important that group therapy or interactive therapy with the same kind of patient is going to be very, very useful. So this is and last one more comment which I have seen. Mm, I think Kankasha, I have answered this about with respect to clinical trial, and how much is the role of preparing parents well actual before this is the preparing parents. Dr. Yusuf, it will. Uh, I will not. We have not assessed that how much parents will be were prepared, but preparing parents again is very, very important. But if you will say, if you'll ask me, I have not done any research on this, but I know that parents, they never remain prepared. But there are, if they are very brave, but will once you will explain them, they will be ready to ultimately of all the eventualities. And they say, if parent is saying that I know what is the ultimate end is very near, but I just want that my child should be pain free. I think this much is enough to hear that they are prepared for it. Okay. Okay, then thank you very much. Any other comment? So if there are no comments, Dr. Nagesh, would you like to say something?
No, Sushma, I think whatever everybody has spoken is correct. It's very difficult to treat children. And as Amelia very rightly said, that the distress of the treating team. Now, I've seen in Karnataka also that when a child passes away, it takes at least 3-4 days for the team to kind of settle down. And a lot of group counseling is useful. So, a very good presentation. And thank you for that.
Thank you, Dr. Nagesh. It was tough topic, and it was he has tried his best to present it in a very nice manner. So, I just last comment, Dr. Kusum, would you like to add something?
Good morning, ma'am. Good
Yeah.
morning, ma'am.
Dr. Kusum is
Regarding
the faculty of nursing college in AIMS, Deodar. Please go ahead. Yeah.
Good morning, ma'am. In the research part, like clinical trials, like DCGI guidelines, and CTI-RI guidelines says, if you want to take the consent of the kid or pediatric group, so less than 8 years, we will take the consent of the parents is okay. And along with that, we have to take the consent of one of the witness along with the parents. And more than 8 years, like child consent along with their parent consent is required.
Very good, Dr. Kusum. It was a good information, I think.
This is like, ma'am, regarding clinical trials guidelines.
So Dr. Punita saying that we have seen very strong parents in chronic ICU. Yes, Dr. Punita, I think parents are very, very strong and brave, and they understand everything well if doctor is explaining them properly. So anyway, thank you very much. I just want to announce that tomorrow there is a very important webinar. Although I will not be in the webinar probably because I will be in the flight that time. But it is an important webinar in the sense that recently what has been amended in advanced medical directives and withdrawal of life support treatment. You know, there are so many questions and so many things which people want to ask. That's why the IAPC has decided that we should keep this webinar, and it is almost for 1 hour and 15 minutes. And I think this will be a very, very useful webinar. And what I will request you and all these people, those who are there in the webinar, you can see that they are right people, those who can answer of your unanswered question. So you will get the link of this webinar very soon. Please join this webinar online. So Archana will send the link to everyone. Thank you very much.
Thank
Thank
you.
you, Savan. Thank you, Dr. Bhavna, Dr. Preeti, and Archana and Nisha and everyone for joining. Thanks a lot. Thank you. See you
Thank
next
you.
Monday.